Hi, this is Jim Berenson, and I'm in West Hollywood, California, and I'm going to be speaking to you all today regarding multiple myeloma, disease I've been working on for nearly 30 years, both in the laboratory and the clinic. And I've picked a especially important topic to talk about today, having just come from the annual American Society of Hematology meeting, which was in San Francisco 2 weeks ago, where we discussed a lot of new drugs. And the topic I picked to discuss today is one that is near and dear to all of you who have myeloma, and that is, as I wrote it, how do you know if you are getting the right drugs at the right doses for treating your myeloma? This is a particularly important issue as the number of drugs become increasing in number and the number of different combinations become so daunting, it's very difficult for those of us who are myeloma experts, let alone garden variety oncologists, let alone other healthcare professionals or patients to deal with. So to start this topic off, I think it's important that you as a patient or caregiver recognize there are several factors that are taken into account to determine what the dose, the schedule that might work for you. These are both disease-related and also not disease-related factors. So when we think about dosing and scheduling drugs, we have to keep in mind that we're dealing not with a mouse in the laboratory, but a patient who has a life. So for some patients, it is rather difficult for them to come to clinic to get infusional therapy when they live hours away from the clinic, whereas if they live close by, that may not be much of an issue. And as I said recently to a lecture I was giving in the Midwest, they said, well, our patients live close by. They live 10 or 15 miles away. And I told them that in Los Angeles, that can be a number of hours in LA traffic, of course. Therefore, I choose to live very close to our clinic so I don't have to deal with that. In addition, there may be issues that the patient has in terms of compliance. So if they live alone and they're supposed to be taking medications and may have some difficulty following directions, it may be more comforting for them to receive their treatment in the clinic in the form of infusion, even if they have to come to the clinic to receive that drug. We also need to take into account the patient's comorbidities. So the patient may have heart disease and therefore may have trouble receiving some of the drugs that can cause heart problems, specifically the anthracyclines, Doxil, the older version, doxorubicin or adriamycin can cause this. In addition, the patient may also have comorbidities that are associated with some of the side effects, such as neuropathy. So diabetics often get neuropathy, and thus they are at higher risk to get neuropathy from drugs that we know can cause it, like thalidomide and Velcade. Now, in addition, on the other side of the ledger is we want to actually know what the disease is about. So you have patients with myeloma, like a new one I saw today, who barely has the disease. Yes, he's got myeloma, and he has some bone disease that requires treatment. We can take our time. We may want to start out with less aggressive treatment in order to see if he can do well with that. And we may not want to use drugs at necessarily the highest doses in his case. And that depends on, of course, a number of factors that tell us that's not what we call high-risk disease. How are his blood counts? His blood counts were normal. He was not anemic. How is his kidney function? This gentleman's kidney function was completely normal. And when the kidney function is not normal, that may be from the myeloma, but it also could be from other diseases like high blood pressure or diabetes. And that may play a role on your decision on what to use and at what dose. For example, a drug like Revlimid, often used up front, the doses of that drug need to be adjusted for the patient's kidney impairment. For example, if the kidneys are doing poorly, you have to use less drug because the drugs are cleared more sluggishly out of the body, they accumulate more, and thus a lower dose is required in a patient with an elevated serum creatinine, that is reduced kidney function compared to the patient with normal kidney function. But what is often confused with that and other drugs is just because the drug is cleared through the kidney doesn't mean it is kidney toxic. It just means you have to use less of it. In addition, you want to take into account the function of the bone marrow itself. And in a newly diagnosed patient, there's often confusion on the part of the local doctor because they go, the blood counts are low, I can't give you that much drug. Well, quite the opposite. I like to say you have to clear the weeds out of the bone marrow and make room for the normal green grass to grow in order for that patient to restore their bone marrow function and to normalize their blood counts. Excuse me. Now, we also want to take into account the extent of the bone disease. Some patients present with very little bone disease and often will have just thin bones altogether, and they certainly benefit from bisphosphonates, drugs like Zometa, Iridia, but they don't necessarily have the kind of devastating bone disease that becomes a big problem, may require immediate intervention. And that intervention may delay other treatments. For example, one of the new patients I saw today who came from an outside doctor had a big plasma cell tumor in the spine that required radiation. So in the process of radiating that bone disease, it precluded that patient from having other drugs because they can both negatively impact bone marrow function, which the radiation can do to the spine, as well as augment the side effects of radiation. So for example, drugs like Velcade and probably carfilzomib, certainly Doxil, adriamycin, these drugs increase the side effects of radiation. So you have to be very careful and perhaps steer away from using them while the patient is receiving radiation therapy for the treatment of that localized myeloma. So in fact, we rarely use radiation therapy in our group to treat myeloma, especially when the patient is early on the course of treatment, because most patients today respond. Now, excuse me, how do you know how rapidly you need to intervene with treatment? Well, in most cases, I like to say, don't just do something, stand there is often a better philosophy. So there are a group of patients, about 20 or 25%, we say, who have higher risk disease, which can be identified through the use of certain tests, such as bone marrow tests looking for the genetic abnormalities that stamp that patient high risk. But in most cases, it's pretty easy to identify those folks. They're patients who come in with kidney failure, plasma cells that are in the blood, plasma cells that have gotten out of the bone marrow and the blood and are now in other organs like the liver, the skin, and patients also who have evidence of disease, say, in other organs of the body. These patients are at high risk, as well as patients who have very low blood counts. When their bone marrow is done, they are just covered with myeloma. We have to treat these patients rapidly and aggressively. So in most cases, it's perhaps okay to take your time, but in this group, you've got to treat rapidly and aggressively. Otherwise, you put that patient at high risk. So in terms of dosing drugs, we have to weigh their activity versus their potential to cause side effects. So we know that some of our drugs such as Velcade, can cause neuropathy, but we've shown very, very convincingly that at lower doses and at longer times for the cycling of the drugs, these drugs can have a lot less side effects than when they're given at the FDA standard doses. So for example, our Velcade dose in our clinic is 1 milligram per meter squared given 4 days a month instead of 1.3 milligrams per meter squared 4 times every 3 weeks. So we give less drug, longer cycle, reducing neuropathy dramatically. Similarly, Revlimid, a drug which is given generally at 25 milligrams for 21 days and 7 days off. This dosing schedule, in our experience, and now we're having to do that on a clinical trial, it's requiring that dosing, is not well tolerated, and many patients require a dose reduction for the side effects that occur: GI, blood clots, quality of life in terms of feeling lousy and fatigue. And at lower doses, I find the drug much better tolerated. And although the FDA has approved the higher dose at 25, most patients in those approval trials didn't actually stay on that dose. We're seeing a similar pattern with the other immunomodulatory agent approved in the last year and a half called Pomalyst or pomalidomide, whereupon the 4 milligram approved dose is one we generally don't use in our clinic. We find the lower doses better tolerated and very effective. Now, one of the things importantly with these drugs, it's not only what drug to pick, but within the drug class, there are differences in their profiles. So, for example, although the immunomodulatory agents, including thalidomide, Revlimid, and Pomalyst, are all similar in structure and action, they can act quite differently. So, for example, patients can have severe neuropathy from thalidomide, which we know is the very, very severe side effect of that drug, much less commonly with drugs in the same class that almost have the same structure, Revlimid and pomalidomide. On the other hand, among those three drugs, thalidomide has very little negative impact on the bone marrow. So in a patient who's had a lot of prior treatment, the bone marrow may have been banged up from lots of chemotherapy and may be at risk. And thalidomide has very little negative impact on your blood counts. So in that case, it may be a drug worth trying instead of a Revlimid or a pomalidomide, which could negatively impact your bone marrow function. But again, we know that as you combine drugs, for example, in this category, the immunomodulatory agents or the IMiDs, you can bring the doses down. So most of my colleagues like using full doses of all the drugs together. I'm not a big fan of that. I believe that if you put drugs together, you can bring down their doses and improve the quality of life. So, for example, if one drug causes numbness and tingling, another drug, say, can cause blood clots, and another drug, for example, can cause weight gain. If you combine them together, and they all have different side effects, but they synergize, that is, work better together, you may be able to bring doses down of those drugs. Now, the second new major class, of course, is the proteasome inhibitors. These include the older drug, Velcade or bortezomib, and the last couple of years approved Kyprolis or carfilzomib. Both are very active. There's a head-to-head comparative trial that's looking at both of these two in combination with steroids. The data is not out yet, but clearly these drugs are very active alone or in combination. But what we know is that, especially with Velcade, again, lowering the dose of that proteasome inhibitor reduces the risk of neuropathy, and yet it's very active. Because, again, these drugs can make other drugs work better. So they're almost can be akin to the orchestra or, say, a play where you have all the supporting actors helping the main actor work better. In this case, Velcade can act as both the main actor and at the same time support the other actors. For example, the steroids, the chemotherapy, or actually the IMiDs as well. Many people today, including the new patient I saw earlier, are receiving Revlimid, Velcade, and dexamethasone, and that triple drug therapy is very active. Whether it works any better in the long run than doublets, we don't know. Recent data presented at the ASH meeting 2 weeks ago suggests that the triplet of the newer version of Velcade, the carfilzomib or Kyprolis, with Revlimid and Dex, is more active than Revlimid and Dex. That is, the remissions were longer. The survival looks like it may be better. But you have to be a little careful interpreting this type of data, especially when the trials are done in all other parts of the world, because it may be that the patient randomized to get, for example, the two drugs never got the third drug when they progress. This is often a problem with trials that we call don't cross over, where the guys who got the placebo and didn't get the real drug aren't necessarily able to get the real drug in other parts of the world like they could in the United States. Now, in terms of the how long to keep people on treatment, there is a lot of controversy on this right now. We don't really know the answer. Is it better to stay on the drugs forever? Is it better to take a holiday? Is it better to kind of do something between where you give a full Monty dose up front and then after a few months cut back? We're not sure. There's not a lot of randomized data. What we know really is that steroids given to a patient responding to steroids and chemo from a trial I ran back 10 years ago improved survival. We also know that Revlimid given long-term with steroids improves survival. versus stopping Revlimid after a year and a half. We don't really know a lot about Velcade or carfilzomib in the maintenance arena. There's not really a lot of good randomized data. We tend to use it, but we use it less often. We try to make it more convenient. So instead of the patient coming in 4 days a month for a Velcade, we have them come in just every other week for that treatment. And we believe that that treatment, or what we call maintenance therapy, to maintain that patient in their good quality of life and remission, should be given until the patient progresses. But we don't really have the data. We don't know if maybe you could have stopped after a year or two and they do just as well. And I've had patients do that. We don't have really good ways to predict for that at this point. I also think it's very important that you recognize that the treatment of myeloma is very tricky, so that, in fact, monitoring the disease is very complicated, and many doctors assume that patients are progressing from laboratories that are, in fact, have been misinterpreted by the laboratories that they're done in. We find that happening all the time. So a patient gets switch therapy, increased doses, changed on treatment or schedules when they didn't really have to do that at all. So we tend to be very much into taking your time, repeating the labs. Now, obviously, if the patient's doing very poorly, the labs are showing dramatic increases, we know the patient's progressing. But in some cases, it's a little more tricky, and things come and go that you think, oh, that doesn't really make a lot of sense. But we've seen a lot of that over the last 30 years of taking care of myeloma patients. Now, by the way, if you have specific questions that you want to ask of me, you can email me either through jberenson, JBERENSON, at imbcr.org, or my assistant T Garceau, TGARCEAU, at imbcr.org. And I'm happy to take your questions regarding the questions of what factors and what doses of drugs. One point I want to make is no two patients are alike. So assembly liming, which a lot of doctors do, cookbooking the treatment, I don't like to do. We need to individualize the treatment. I have patients responding to, for example, pomalidomide at doses as low as 1 milligram and as high as 4 milligrams. So I can't tell you that we have really good, solid data, for example, with that drug, and as well with Revlimid, that we know that lower doses would not work just as well. And I have patients, in fact, who then progress. You increase the dose of these drugs like Revlimid, POM, and they respond. And we're doing a study to see if the same is in fact true with carfilzomib. Patients who fail the lower dose, we're trying to see if higher doses can be effectively used with them. And we're also doing studies with that drug to use it once a week now. We presented some of that data, and we'll be updating it soon and publishing it on a once a week dosing of carfilzomib at a much higher dose. And certainly we're hopeful that that schedule will be very safe, very well tolerated, very effective, and certainly more convenient in LA traffic than the current twice daily, 2 days in a row, weekly schedule we have right now. Of course, people have used alternative scheduling of Velcade already. Some people use it once a week rather than twice weekly for 2 weeks. Like the patient I saw today was getting it that way from an outside doctor once a week. We don't really have a lot of data to suggest that works any worse or better. So a lot of these questions are unanswered. So your doctor being absolute about this in terms of dosing or schedule, I don't think so. And obviously, if you're on a clinical trial, all bets are off, and you're going to have to stay on that consistent dosing, consistent scheduling of the drug. So I will tell you that there are a lot of factors that go in determining what the dose, what the right drug, what the schedule is for you. And don't accept that you have to get the drug at the FDA-approved dose and the FDA-approved schedule. That's only one way to do it. There are a lot of other ways these drugs can be used, and quite effectively, and in many cases, in my view, much more safely and a much better tolerated form. I think that's the important thing, is to maintain not only the remission, the patient's quality of life, while they're receiving therapy, because really you're going to be on therapy probably constantly now. The old days of drug holidays are going away. Until we get a cure, we're trying to maintain you in that remission for as long as possible. And I think I'll see if there's some questions for a moment here. Let's see if I have a question. I don't see any currently, but I'll see if my assistant has anybody that they want to have a question. But I guess let me comment for a bit on the updates from the meeting we had at the hematology meeting. I'll let you know there are a lot of exciting new data. We have a lot of antibodies that are moving along. We have antibodies to targets on the myeloma cell. We have anti-CD38. There's two forms of that now in late development, a so-called SAR form and a form called daratumumab. And these are that from Janssen that are in late development that are very exciting and particularly boosting the activity of other drugs. Similarly, an antibody to SLAMF7 or anti-CS1, an antibody treatment developed from the group at Bristol Myers Squibb, both directly kills myeloma and activates the immune system. Seems very active when combined with Revlimid and Dex. And then, as I said, the very compelling large study suggesting that carfilzomib or Kyprolis Rev-Dex may be more active than Rev and Dex in people who've already failed their first-line treatment. A lot of very keen interest in that as well. We do think that these antibodies will hopefully be approved fairly soon for the treatment of myeloma. A lot of studies going into using these antibodies up front. I would also tell you that mostly these days, patients will get a response to their first, or if they don't to the first, by the second treatment. So the response rates to first treatment are 90 and above percentage, meaning that the protein has dropped at least 50%. And even if it doesn't work with the first treatment, if you have the second in, it's well over 95%. So it's pretty uncommon that you don't get a response. One of the problems we find is that patients with high-risk disease, although they'll respond, not very long. And this very small group, about 15-20% of patients with high-risk disease, we really need to find better ways to deal with that disorder. They're the problem patients or the problem children. We don't have good drugs yet. We just don't know what to do with them. We certainly know that with transplants, they don't do very well either. In our own group, we're a firm believer that you have to stay in the marathon as long as you can. So we think that running longer miles, less drugs, if you will, less dosing of drugs, you may finish the race. More drugs may allow you short-term benefits, but we're not convinced in the long run that's the right thing to do, as it compromises your future ability to respond to treatment. So let's see if I have any queries yet. All right, not yet. So if you have questions for me, please feel free to bring them to the attention of my assistant or myself at jbarronson@imbcr.org or at tgarceau, TGARCEAU, @imbcr.org. I will tell you that we do believe that the newer drugs will, again, increase greatly the number of options for you. And one of the important things to recognize that in terms of using drugs, those drugs that may not have worked in one combination may be quite effective when used with another drug. We've shown that repeatedly now over the last few years with Velcade. We're now showing the same thing with carfilzomib, and the same is true with the IMiDs, whether it's thalidomide, Pomalyst, or Revlimid. So in the past, as oncologists, we tended to abandon drugs once you had failed that drug. So if you failed that drug, we'd never try it again. Not true anymore. These drugs, again, can be the supporting cast to make other drugs work better. I always like to make the analogy to the I Love Lucy show, and Lucy and Vivian eating the chocolates after the conveyor belt. We have a lot of different conveyor belts that bring us different chocolates now. We have these IMIDs, we have the Velcade, the carfilzomib, and then the chocolates can be lots of different drugs, chemotherapy, steroids. We now have the antibodies coming along as well. So a lot of different options to help our patients. We also are not afraid to decrease the dosing of these drugs. For example, although steroids are used quite commonly at one dose every week orally, we believe that other formulations of the drugs of dexamethasone, such as methylprednisolone or Medrol, and when given every other day, can be much better tolerated. Similarly, IV administration of the steroids can take away some of the terrible mood effects that patients experience when they feel poorly and they crash when they can't sleep, and then over the next few days it can be wiped out. We find that methylprednisolone really helps a lot, or Medrol, with that when we give it every other day than the once a week, what we call pulse therapy use of Dex. I think these are things can make your lives a lot better. But again, I have patients who say still too much drug, and we decrease the dose quite a bit. We don't necessarily stay with the dose that was fixed in the original publication because the patient may not tolerate it very well. So I think this is also important to keep in mind as you tackle your myeloma. So I think, again, a lot of different factors come into play as you decide about what drugs to use and at what doses. In general, the drug doses that can be used, I believe, are lower, tone it down, and cycles longer, giving you more time to have off of therapy, to have better quality of life. And we think we see that all the time in our patients, and we're very, very, very sensitive to their needs in terms of reducing doses. And you may say, well, you're compromising the effectiveness of the drugs, but I would tell you at the same time that we want to make sure patients have quality, and we monitor our patients very carefully. And if the drugs are not working, we're happy to adjust that very quickly and bring them either a different schedule or add another drug in. One thing to keep in mind, though, is as you add drugs in, you may have to reduce other drugs. So, for example, patients who are on a Velcade schedule with chemo, when you add another drug that can affect the bone marrow, such as a Revlimid, you may have to reduce the dose of the chemo. Similarly, steroids, a lot of people have tried the antibiotic Biaxin to increase the activity of steroids, but it also can increase the side effects. Some patients may require less steroids to compensate for that increased toxicity of the steroids when you combine it with Biaxin. And basically that antibiotic can, if you will, like stopper up your sink so you accumulate more steroids. They don't get cleared out as quickly, kind of like the kidney failure patient who can't clear out Revlimid. And thus, with the Biaxin treatment in a patient on steroids, you may have to cut the steroid dose in. Let's see if we have a question here. So the question is, what is the advantage of going back to an older drug, that is Treanda, versus the newer drugs coming out? Well, I wish I could clearly delineate that. And that obviously has a lot to do how you did on that older drug and how long ago you got it. So, for example, I had a patient who was on one of our favorite upfront treatments with Doxil, Velcade, and Dex. He came over here from India on dialysis, did great for several years, decided to stop therapy. His disease came back, and about 2.5 years ago, 2 years ago, he went on a clinical trial, and he had a nice response, but the drug affected his kidney poorly. He had to stop. And then he went off all therapy for about a year, and disease came back. We went back to that old therapy. You know what? He went back into remission where he is today. So you can often go back to the old therapy and it'll work. And I think it's important to keep in mind. He may have stayed in remission even on that first therapy had he stayed on the maintenance treatment. Of course, you have to take into account how you tolerate it. So obviously, second drug he got caused kidney failure. We're not going back to that drug. There may be that a drug that you used in the past, like a Doxil, worked with, say, Velcade, and now we can try it with an immunomodulatory agent like Revlimid or Palm. We're doing that trial right now with Palm Doxil Index. Most patients are responding. So you can try that old drug again with a newer drug like Palm. In terms of trying a new drug, like say a Trianda, which we use a lot of, bendamustine, not approved for myeloma, but very active. We do believe that that is a very active drug, even in patients who fail similar drugs, what we call alkylating agents like Cytoxan or cyclophosphamide, Alkeran or Melphalan. Those patients often respond to bendamustine, so that's a great drug. The choice of when to do it, not a lot of clear data on the algorithm and what order to give these drugs. We're trying to answer that a little bit in our animal models now. We have animals growing human myeloma, and we're trying to sequence these drugs as animals failed previous therapy, but we don't really have a clear-cut answer yet on it. So unfortunately, not a lot of definition about when to toss out the old and throw in the new, but we try to make very few changes, because if you start using 4 or 5 different drugs at the same time, you don't know which ones were really required to get the remission. But if your patient has developed poorly, very, very aggressive myeloma and feeling poorly, say they're getting more anemic, kidney failure, you got to throw the kitchen sink. You can't wait to try things out, because it may be a month is too long and you may don't have the opportunity if you blow it. So in those cases, we're going to go for more drugs and perhaps at higher doses. But in most patients, you can take your time, even in patients who had prior therapy. Let's see, we have a number of other questions. Okay, let's see. Please explain your position regarding using alkylating agents as frontline drugs. Okay, very good question. A lot of people on the West Coast receive Cytoxan, Velcade, and Dex, so-called Cyborg-D therapy, came out of Mayo Clinic Scottsdale. Very active regimen, in my view, much too much Cytoxan. We use about 1/3 of that dose. In fact, I got an email yesterday from a doctor saying to use what? Because you don't really need all that chemo when you give Velcade, because Velcade makes chemo work a lot better. You don't need all that chemo. The alkylating agents use up front has been somewhat tempered in its usage by the fear that you may make the ability to collect stem cells somewhat difficult. And although that can be true, it's all about dose and schedule. We use, again, much less drug. For example, our alkylating agents, Melphalan or Alkeran dose is about 30-40% of the standard dosing. Because again, as you combine drugs, when one drug makes the other look better, you don't necessarily need to use full doses, because when you do, you can have off-target effects on healthy bone marrow. We're not at all afraid to use alkylating agents up front, but generally we use Doxil up front, but we certainly use a fair bit of Cytoxan and even Melphalan. The fear has been that you will kill the stem cells and not allow that patient to have a bone marrow transplant. That's been the fear. We do not feel that's justified, certainly given our dosing and scheduling of the drugs up front. A lot of people these days are using Revlimid and Velcade together up front with steroids, so-called RVD therapy. Unfortunately, that's pretty darn expensive therapy, and there's been no demonstrated it's better than Cyborg-D instead of the Cy used instead of the Revlimid. We don't know the answer. Both are very active up front. And we certainly use a fair bit of Revlimid up front as well, although not commonly, except for in high-risk patients with Velcade and Dex. We tend to use that in patients who like to move and groove and don't want to come to clinic too often. Those patients who like to be in airplanes a lot may not be able to come to clinic to get IV therapy as often as required by the Velcades and the Kyprolysis. Let's see, we have another question. Somebody said we're coming through with two voices. I'm sorry if that's the case, but here I'm coming through with one voice loud and clear. So there's some other questions out there for me. Let's see if there are. I think I have one right here. This is a patient who has liver involvement with myeloma. That's a pretty daunting thing to overcome. So again, when the myeloma is outside of the bone marrow in the liver or the blood, it's much tougher to treat, needs much more aggressive treatment. We certainly need better drugs to treat that kind of disease. We, however, have had very good success now over the last few years in patients who have plasma cell leukemia, or the plasma cells, the cancer cells, have now jumped out of the bone marrow and the blood. We have a lot of good treatments now for that, and patients staying in long remission. We didn't have that 5 or 10 years ago. So the newer drugs, the immunomodulatory agents, the proteasome inhibitors, together especially, we're doing a good job of handling that disorder. We never were able to do that a few years back. All right, we got another question. So the patient is now on low-dose Velcade, Revlimid, and Dexo, that combination I just talked about, for 8 months. They were considered to be high risk on a genetic profile. They had only a couple of bone lesions, and they haven't really changed their numbers much, but they haven't gotten any worse. And the doctor's considering changing their therapy. Well, they should know that there is a subgroup of so-called high-risk people that do just fine. And I would probably argue that you may be in that subgroup. So we know that high-risk patients will respond, but they rapidly relapse. In this case, our patient is sitting still, not moving the numbers, but certainly not getting worse after 8 months. So looking back is kind of telling us your disease is not moving very much. I probably wouldn't be inclined to change things very much based on just a genetic profiling. So I don't think that's going to tell us that much. Let's see if we have another question. Well, I think another important point to bring up, we are developing new ways to categorize patients at low or high risk. Our laboratory has recently identified a new blood marker to do that. Simple serum test. Instead of measuring IgG, M protein, or serum free light chain, we believe that the serum BCMA, or B-cell maturation antigen, will give us very, very important data to follow your myeloma and to predict your outcome. This is not a commercially available test yet, but we are certainly very interested in bringing this to the clinic over the next few years. It's a lot easier, we believe, to determine risk on that than what we've done in the past with bone marrows and cytogenetics in fish, which is very expensive and cumbersome. That test, we believe, will help a lot to classify patients without the cumbersomeness of the bone marrow. And we just talked about this patient who's considered high risk, but not really acting like it in the last 8 months that she's been treated, in which the disease has not really gotten worse, not really gotten better. Do we have some other questions out there? Well, if not, I'm going to wish you all a good evening and thank you for your attention. Thank you very much.